Hello, everyone. I am Dr. Vaishnavi Pradhan from the team of Voice of Healthcare, and I'm delighted to welcome you to another insightful episode of our World Diabetes Day special podcast series, Diabetes 360 Degrees Shaping the Future of Diabetes Care. This series brings together renowned experts to help us unpack the evolving diabetes landscape and understand how India can embrace a more holistic, patient centered, and future ready approach to diabetes care. India continues to face one of the world's largest and fast growing diabetes burdens. What's especially concerning today is the shift we are witnessing, which is younger onset, rising pre-diabetes, widening access gap, and increasing comorbidities. Beyond clinical care, diabetes challenges a person's emotional well being, family environment, workplace productivity, and daily lifestyle choices. Through this series, we aim to explore these interconnected dimensions and understand what a truly 360-degree diabetes care ecosystem should look like for India's future. To guide this conversation, I'm honored to welcome Dr. Beena Bansal, endocrinologist and diabetes specialist and director, Door to Door Care, Endocrine and Diabetes Clinic and Research Center. So, welcome to our session, ma'am. It's a pleasure to have you with us.
Hi, Dr. Vaishnavi. Thank you. Thank you for having me here.
So to quickly start with and help us understand that how are we aligning ourselves to national efforts and global goals? If you can help me understand that how can India adapt to international best practices or global diabetes framework to strengthen its own national strategy for prevention, access, and outcomes?
Um, so, India is one of the largest places where diabetes is prevalent. Like it's called the diabetes capital of the world, and lot of so there are a lot of very special things about diabetes in India vis-a-vis globally. In countries like India and China, the way diabetes presents itself and the way it has evolved over the last few years because of the socioeconomic transition is much different from what we read and see in Western counterparts. So we have special challenges. I mean, there are global standards, but um, and of course, I mean, diabetes is the defining disease of the century, and the way we define diabetes is going to determine a lot of longevity in future, and it doesn't seem like abating at any close time. So at a national level, the question you are asking is, unless we take it at that macro level, uh, as a doctor, I see patients in the clinic, and there are challenges there in the clinic. Patients come to us, they have their unique problems, but those patients, they all can afford treatment. Those who come to private clinics, those patients who are already aware, who are already diagnosed, but there is a bigger population who don't even know. 50% of people don't even know that they have diabetes, and they end up diagnosing diabetes only when when they present with complications. So the later the diabetes is diagnosed, less we can do, because once complications set in, the treatment becomes very expensive. And because we have to mostly pay from our pockets, we most patients cannot even afford those treatments like dialysis or heart intervention, etc. So there has to be, of course, and there are NCD programs at a national level which kind of have taken this as an agenda to um, diagnose it at an early stages where it is most cost effective to intervene, so that we can, number one, prevent progression from pre-diabetes to diabetes. And in fact, now obesity is being addressed at a major level. um, we have been considering the lifespan approach, that we have to start early in life to prevent obesity as an adult and to prevent ultimately diabetes from developing, so that we can prevent complications. So there has to be a life course approach, um, school based policies which address how food is available to us, how we can avail more healthy nutrition, maybe school meal policies, etc. So there are a lot of efforts which are being taken, which can be taken at a national level, so that we can deal with this huge problem. Of course, I mean, still it is like a really, really big problem, and there are so many things which need to be done at so many levels. So, national program for screening pre-diabetes, school-based policies, opportunistic screening at workplaces, in our clinics, etc. So there have to be a lot of efforts to
So, do
reach.
you think, yeah. So, do you think that India is now seeing a shift towards earlier and more complex cases, and what might be driving these changes that you see?
So we are sitting in Gurgaon, and obviously, here in a place like this, where most people, they have highly sedentary lives. There is a huge IT sector, for example, and the work hours are huge, like long working hours, and it's so common now to see fathers bringing their son to the clinic rather than the other way around. I mean, that's the shift which is happening. The uh, generation just prior to us is much healthier than the current generation because of change in their sleep timings. There are a lot of shift duties. The sedentariness is it's an epidemic of sitting. In schools there is hardly any sports period. Workplaces are very, very, very sedentary, and they work really long hours. So even if you want to introduce activity in their day, I mean, just going for a 30-minute walk doesn't help if you have to sit 10 hours in a day. So there is definitely a shift in the way diabetes is being diagnosed. Overweight, obesity, and a very young onset type 2 diabetes is happening. And it seems that young onset diabetes has a very different presentation and pathophysiology as compared to older onset. So, diabetes before 30 versus diabetes after 40, the prognosis immediately changes.
Right.
We see childhood diabetes very commonly. They not only have diabetes, but all the other metabolic complications which are associated with it. And most important of that is the what we call as metabolic syndrome associated steatohepatitis. So there's fatty liver and the associated complications. That's another associated comorbidity which is increasing equally rapidly. So yes, there is a shift. um, there is change in our lifestyles, the work habits, the way food is being ordered, and how difficult it is to manage cooking at home. Women in workforce, that's hardly been kind of planned, taken into account.
Correct.
No one kind of even thinks how caregiving at home will happen, and that's not there in any job profile. I mean, it's so difficult to make that a part of our work culture, that
Correct.
someone has to also take care of things at home. So, I mean, you understand all those complexities, which actually
Yes.
these small things are what are driving the whole diabetic epidemic. Yeah.
We are in a loop. We are stuck in a loop. So, early diagnosis remains a major challenge, especially outside urban areas. So, what models or innovation can strengthen these screening and follow up at the primary care or community level?
One of the simplest things, and there have been kind of some efforts to do that, is to maybe just do a random glucometer testing for people using community health workers like ASHA workers, ANM. So that's one strategy, using primary healthcare workers to do a glucose testing uh, for most adults, but definitely for women, especially pregnant women, because that's one way of abating the whole epidemic. Because if we take care of the pregnant women, it also ensures that the kids who are born have less risk of diabetes. That's, I think, one strategy. Technology is coming a long way, and I have heard of programs where those community health workers are provided with tabs and all, where they can immediately relay the information of the patient so that all of that data can be recorded. Having said that, I think there are a lot of AI based trials going on world over, and hopefully, we'll see, looking at the development of all of these newer technologies, glucose monitoring still is an invasive method. So people are trying to figure out other easy ways, some facial features to diagnose a lot of chronic disease. It seems like a very sci-fi kind of a movie kind of a picture, but that's the reality. For example, uh, eye photography, retina testing, some facial features. So people are trying to collect data from a lot of people, and they're trying to correlate it with which are the features which can immediately, just on scanning, because face recognition is becoming quite common everywhere. Can we predict risk by even less invasive methods? But blood glucose testing using a simple glucometer is one way where opportunistic testing, at least for people who come to the clinics. Definitely, we should screen all pregnant women. I think these are some of the measures which can help at a community level.
Correct. So, I mean, diagnosis and screening is one part of it, but there is another, which is many patients they fall through the cracks after diagnosis. So, due to irregular follow-ups or medication gap. So, what strategies have found effective in improving treatment adherence and long-term disease control?
Um, so there are many reasons because of which people don't follow up regularly. Um, One, it is not an easy disease to kind of follow up with. There are routine monitorings required. There is a lot of things which are expected from the patient. You have to check your glucose, you have to do your tests regularly, you have to take care of your diet, and you have to take care of your exercise, etc. So that is one important thing. Sometimes uh, to get the concept of a chronic disease is difficult for people. They think that one visit has happened, now their glucose levels are controlled, they don't need to do regular testing. That is another thing, or just life just takes over. That's third part. But I think one of the things which are happening lately in our clinics, and I am sure other diabetes doctors may also be facing that, is although now we have media which can help people understand more about diabetes, there is so much of information which we can easily get at our fingertips. But instead of right information being spread, it's misinformation which is spreading more commonly.
Correct.
There is a whole social narrative against medicine. um, Even this whole diabetes reversal narrative has been counterproductive. What happens is people kind of start stigmatizing taking medicine as if it's a failure to take medicine. That's the kind of story which is storyline, like I have reversed my diabetes becomes a success story. Therefore, if you have not, it becomes a failure story. So that whole thing, not understanding the complexity of diabetes, that not everyone has a similar kind of diabetes. There are so many pathophysiological factors behind it. It's not all lifestyle. It's not because you have done something wrong that you need medicine. That needs to be kind of emphasized again and again. So many a times when patients come, the first consultation, first visit, we try to frame the whole thing in a proper manner, that it's not your fault, this is why diabetes happens, and ultimately to put in perspective that whatever we are doing is to ensure that for next many years, 40, 50 years, you live a healthy and long life. It's not a competition between you or someone else with diabetes, or it's not a test of your willpower. I mean, as simple as that. So these small ways to communicate the messages properly is important, so that they keep continue following up with the doctors.
So I have like a very impromptu question. I mean, it was not anywhere, but as we talk about hypertension, that it cannot be reversed. So
Hmm.
is it the same for diabetes, or is there a chance that it can be reversed? Is it possible or not?
That's like everyone is curious about diabetes reversal, and hypertension also, by the same logic, can be abated. The word is not reversal, it's remission. Uh, so there are things which happen because of genetic factors, metabolic changes in the body. But as I said, there are so many important lifestyle factors which are leading to higher levels of glucose in many people, like sitting for long hours, um, not having healthy food choices, or not knowing about how to plan your meals. Suppose those factors are taken care of to a certain extent, uh, the glucose levels will come down and they may not need medicine. People who were needing medicine but they start walking, for example, every day,
Mhm.
they might become, the glucose level can get in control without medicines also. And if that happens, at least for 3 months, no medicine for 3 months, but HbA1c less than 6.5. That is an important condition. Then it is
Hmm.
called diabetes remission. It may last for 3 months, it may last for 3 years.
Hmm.
Why the word remission is important rather than reversal is that you still need to keep monitoring because it may come back. It's not
Correct.
like forget about it. So,
Correct.
and then they keep thinking about that 3 years back I had reversed it, now it is back. It hits them even worse that time. I don't know why. So again, even if they are able to go into remission, we congratulate them because it's a healthy thing. But that's okay. And if you need medicine, if you don't need medicine, I mean, I will look at them in a same manner. I'm not going to be saying that, oh, you did such a good job or you did not do such a good job. So the report card is not going to change there.
Correct. So managing diabetes is like a lifelong journey, as we are addressing also that it is a remission of diabetes rather than reversal. So often it brings emotional ups and downs also. So how can healthcare providers better support these patients in dealing with their burnout, fear, or frustration related to this condition?
Right. So what I've been again and again trying to say is how the patients are telling their stories become very important and how they're going to carry it forward, because this is now part of their identity. Diabetes is now going to be with them, and that's the most difficult part to assimilate in their systems, that now I have diabetes as well. So this narrative framework helps. Listen to what they're saying. Are they framing it like, oh, I messed up my life, I did not do this? Have they started blaming themselves, or is there a lot of guilt and shame going on? And that has to be taken care of then and there. That it's okay. I mean, it's completely human and you're allowed to make mistakes, but this is how we go on a learning curve beyond that. So a narrative framework where they can be shifted, or the stories have to be reframed every time. That's very important. Not always as clinicians we can provide that much of time. So having a good system of counselors and educators and nurse educators, they really help. And in fact, they are sometimes better listeners and better communicators than the doctors themselves. So, and patients are more open to them very often. So having a team of people who can talk to the patient, have a relationship with them, not just a prescriptive relationship, but someone to communicate with. They can come and share their thoughts, so that that can be taken forward. So a communicative approach helps. I think that's the most important thing.
Correct. So we have also seen that women often face unique barrier in accessing diabetes care, from household priorities to gestational diabetes risk, etc. So, what approaches do you think can be taken to have like a more gender sensitive and accessibility that ways?
So, as you said, there are so many other things, other priorities in women's life, as I was mentioning earlier also. And if we look at diabetes as an epidemic and obesity as an epidemic, it's said that these are all, I mean, more empowered a woman is, more gender inequality, higher the risk of diabetes, in fact, in countries. And they are going hand in hand. And there is a reason behind it. Because, I mean, the whole planning of meals and cooking and everything comes on women majorly, and it's still assumed that they are going to do that. So because sharing of that burden is not happening, I mean, women are still prioritizing all the care work and also working outside. That is shifting a lot of eating habits from cooking at home to ordering from outside, etc. So not going into that, I think definitely women from very early on in life, they need to understand that their health is a priority. They are not doing it always for someone else. Gestational diabetes is made such an important thing because now you have to take care because of your child, rather than telling them that it's because of your own health that it is important that we take care. So that's one. Um, Also, I mean, what we see in clinics, even my educators with me, they also point it out very often, that there is a lot of policing which happens. Either the husband is telling that she is not following a diet, she is gaining weight, she doesn't go for a walk, and not going behind the, and she would be telling that morning there is so much to do, you can go out for a walk, but someone has to stay there and cook the meals and prepare the tiffin, etc. um, s- and for mothers, sons are doing the same thing. So it doesn't end there. I mean, they'll say that she doesn't follow a routine, she doesn't eat on time. And as soon as you kind of start speaking on their behalf, that um you should ask her, maybe, I mean, she must be for good, doing something good. I mean, you have to be on their side. And many a times they also start crying in the clinic because no one is listening to them. They are always policing them that you
Hmm.
have high glucose because you're not taking care, and it comes very strongly for women rather than men. So all of these factors, I mean, overall, how the society is, the culture at home, um, that impacts their health so strongly. They don't even sometimes know what the medicines are. They are hesitant to go out and spend on themselves for the test. I mean, women more than men. All of these factors are, I think, affecting access to care.
So, I mean, in your journey so far, since you have been taking care of these activities, etc., have you ever come across any activity or something that has happened on a community level, which has been women led, or for addressing these gaps? Has there been something, or it is still yet there, not addressed?
So I have personally been trying to do some women endocrinology conferences. So we did Female Endocrine Meet FEM 2019, 2020. There were two, three conferences, humanizing medicine. Unfortunately, over the years, a lot of other women endocrinologists are doing that. And now there is a women endocrinology wing, which takes care of, uh, which focuses on endocrine disorders, especially diabetes in women. There are societies like Divas and Flame, etc. There are a lot of different regions. People are trying to address it on behalf of. I mean, at least the women doctors are coming together. Women and male doctors are coming together to address women-specific issues. At least start those discourses on how to have a gender-sensitive clinic, for example. Uh, that is definitely happening. What we have been trying to do, not very successfully, but maybe we have not structured it well enough. But now we are focused. So social prescribing is something which is, I mean, a new term, and conditions like diabetes need that. One way which we are thinking of doing it is to have a group consultation or bringing a group together to discuss. So women centric issues like obesity or gestational diabetes or PCOS or diabetes in women, rather than talking individually in a consultation, we want to bring 5 or 10 women together, because sharing their stories might help in empowering them, might help in understanding that they are not alone. I mean, that's something which we have been considering. It needs a lot of planning and coordination, but I'm sure other communities must be there. I mean, some informal mothers or kitchen communities or cooking communities, those kind of places where women go out and use that forum to discuss their barriers, etc. But in a formal way, I am sure there will be many more which will come up, and those are very much required, because
Yes.
the problems are different and the solutions also need to be different for them. Uh,
Correct. So I believe through maybe our session or forums like these, also such things come out, and such things are given like a thought that okay, this is also something that has to be done. So now we have a lot of technological adaptation and advancements also. So technology, from continuous glucose monitoring to teleconsultation, is transforming diabetes care. So how do you see these digital tools changing the engagement and clinical decision making altogether?
yeah. No, so the newer technologies have really helped in last few years. The use of CGM or continuous glucose monitoring devices, the devices which can measure glucose all throughout the day, has really shot up. And they have helped patients. It really empowers patients. They understand how the medicines are working, how their food is affecting their glucose. So, especially patients on insulin, adjustment of insulin, etc., they're able to do much more effectively. So patients who start using it regularly, of course, it's an expensive thing. Not everyone can afford that, but people who afford it and are using it, they see a dramatic change in their overall control and confidence in managing their own diabetes. So CGM helps. There are other technologies for type 1, for example, insulin pumps, etc. Are there. Also, there are certain apps which help in improving decision making for diabetes patients. So technology is the next way forward. I mean, that has come, that is going to increase in future. There are lifestyle wellness technologies like how much exercise you're doing, tracking your meals, etc. All of these are clearly helping in managing people with diabetes.
Right. So, I mean, now that we have covered all these topics, diabetes management today, it goes beyond glucose control. So, how important it is to have like a multidisciplinary approach involving nutrition, psychologist, and educator, and endocrinologist for sure. So, how important it is in current scenario?
It is very, very important, as I already mentioned. So, diabetes is not just a medical disorder, as you have been pointing out. It impacts patients' life in such a big way. It's a psychosocial uh, issue as well. So, people who can talk to the patients for a long time. So, if you have educators, that really helps. Not everyone can afford to have psychologists all the time, but there are patients who really need help from a psychotherapist or a psychiatrist, so they can be referred to a clinic where psychologists are there. Uh, Trainers and physiotherapists, they are definitely an important part of the whole management. So a lot of the counselings in most clinics are done by diabetes educators. They kind of learn a bit of all of this, and they do multitasking that way. Uh, because educators spend at least 30 minutes to 60 minutes with each patient. You need multiple educators to take care of so many patients which are there. Whereas doctors are busy in kind of figuring out the treatment plan. The role of all of these together is very, very important. If the patients have to monitor glucose regularly at home, follow a good meal plan, stay in touch with the team. So I think diabetes management is always a multidisciplinary team
Correct.
management.
So now I think we are just in a bit to wrap up the session. I mean, for our viewers who have been listening to us, we have spoken about early management, early screening programs, how important it is in the community level, and these women-related or gender-related initiatives that we need to have. So, how would you like to like give us a summary of all this, and what would be like that one takeaway home message from this session for all the viewers who are listening to us?
If you have never checked your glucose levels, do check it. Don't be scared that you'll find a high level. Uh, get your glucose and HbA1c tested. If you already have diabetes, again, it's important to look at the glucose level, monitor them regularly. Uh, don't take it as a report card. It is something which will help improve your management. So try to analyze why the glucose pattern is in a certain way, and it's an iterative process. You may follow certain diets for some time, you may not be able to follow, and that is how it's true for most of us. I think perfection is not the goal here. Ultimately, learning and growing over the years. So having a growth mindset, like in anything else, is very important in diabetes management. That make mistakes, learn from them, and grow at each step. Don't try to achieve perfection, because that's that's probably not true for anything, not just diabetes management.
So, I mean, I would like to thank you so much for joining the session and sharing those insights. It was like it was a pleasure talking to you and knowing all those insights and how this situation can be addressed altogether. So, we look forward to have more such initiatives and such sessions so that things get addressed at times. And I mean, we all give it a thought. Maybe someday somebody takes up something which is not yet addressed through these forums. So thank you so much for taking out your time, ma'am, and it was great talking to you. Thank you.
Thank you,
Thanks a lot.
Vaishnavi.